Hello and good evening, everyone. Welcome to our 44th Blue Health virtual seminar. Blue Health virtual seminar is a platform that allows health professionals. Blue Health virtual seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. This platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Iheno Tadela, a general physician and first aid trainer from Blue Health Ethiopia. Today, it's a pleasure to have Dr. Alpha Seifu here with us to present on the topic Polytrauma and Damage Control Orthopedics. Dr. Alpha is not new to the platform. She previously had 2 sessions with us on basic principles of fracture management and pediatric trauma injury to musculoskeletal system. So Dr. Alpha Seifu is an assistant professor of orthopedic and trauma surgery, and she's a surgical care equity advocate as well as a researcher. Dr. Alpha, the stage is all yours.
Thank you very much, Dr. Iheno, for that generous introduction. Today's topic of discussion is going to be damage control orthopedics and polytrauma. So we're going to see how to approach orthopedic trauma within the context of polytrauma. So before we jump into the content of the presentation, I want to start you off with a case that we're going to come back to at the end. So here's the history. A 46-year-old male patient. He's a pedestrian hit by a fast-moving car, and he presented with neck pain and a transient loss of consciousness with bilateral lower limb pain. So on physical examination, he's acutely looking in pain. All vital signs are deranged with a pulse rate of 121, and BP has dropped down to 100/70, and respiratory rate is 24, and saturation is 94 on atmospheric air. So we'll come back to see how we're going to approach this patient. So the content of my presentation we'll see a brief introduction, followed by an evolution of fracture care in polytrauma patients. We'll try to briefly see the molecular aspect of damage control and how to grade patients following trauma, and patient selection for damage control orthopedics. We'll also see the efficacy of damage control orthopedics and secondary procedures. And we will briefly discuss early appropriate care, which is the new trend in polytrauma and orthopedics. So as an introduction, trauma is on the rise in low and middle income countries, and it primarily affects the young and working group. So it's killing off men below the age of 40 worldwide. And it also results in devastating disability compared to other diseases. So worldwide, around 16,000 people die every day as a result of injury, becoming a major cause of mortality. And you all know about the concept of the golden hour concept, that 60% of preventable deaths actually happen within the first hour. But today's topic of discussion is going to see another significant hour following the first hour, and the decisions we make following that could also lead to high levels of morbidity and mortality in polytrauma patients. So once multi-organ failure occurs, the mortality exceeds actually 50%. So most of you are familiar with that, I'm sure. So here's an image trying to depict the leading causes of death in young patients. Just to reiterate what I've already said, here you can see that motor vehicle accidents are top on the chart, and other causes of trauma follow motor vehicle accidents, like unintentional injuries and homicide and suicide. So these are the major causes of death in young people, and the trend is only going up. So here's another depiction showing the details to what unintentional injury it constitutes of, and the major causes of death, again, motor vehicle traffic accidents are top of the list. So before we discuss how to approach a patient with polytrauma, we have to clearly define what polytrauma means. So it's a combined trauma in which there are 2 or more severe injuries that affect at least 2 or more anatomical regions. So rarely 2 or more severe injuries in one anatomical area could be considered as a polytrauma, whereas at least where one of them is at least life-threatening. So in that case, we define that as well as polytrauma. So a more objective way of defining polytrauma would be an injury severity score of 16 or above. We'll see how to calculate the injury severity score for patients. So ideally in polytrauma patients, it requires a multidisciplinary approach, and it should ideally be treated in a designated trauma center. So before we see how to calculate the injury severity score, which we heavily rely on, we should see how to classify or score the different trauma scoring systems. So it can be based on anatomy, physiology, or the combination of these. So I've already mentioned injury severity score, but there are other anatomical ways of classifying trauma patients, or classifying a trauma in a patient. So the abbreviated injury scale and the new injury severity score are part of the anatomical classification systems. And there are also physiological ways and combined ways of classifying trauma. In clinical settings, these are more important for research and data keeping, and for policy development and the like, for research purposes mainly. But in clinical setups, it might be time consuming and also sometimes unnecessary to make these calculations. Maybe someone who's responsible for the research department in an emergency room could take charge of that, but I don't think every clinician should stay busy calculating severity scores unless it has clinical implications, but it's good to know them. So before we calculate the injury severity score, we have to know the abbreviated injury scale or scoring system. So these designated numbers stand for the injury described adjacent to it. So it's minor, it's 1, moderate 2, serious 3, and the list goes on. There is a certain subjectivity to these systems, but they're largely used in clinical setups. We use the injury severity score for research, for just international communication as well, because scoring systems are important so that we can all speak the same language. So when I say the injury severity score is above 20, someone knows that this is a polytrauma patient. So yeah, you use the abbreviated injury score, and you take the sum of the 3 highest abbreviated injury scores and then square them. That's how you get the injury severity score for a patient. So let's say a patient has a flail chest, he has a bilateral femur shaft fracture. So these are the highest scoring AISs. So you take these and then maybe a small laceration on the head, and that's it. So these are the 3 highest ones, and then you score them, you find the AIS for each, and then square that, and the sum of that is the injury severity score for a patient. So having said that about the severity scoring systems, let's see the evolution of fracture care in polytrauma patients. So the way we approach orthopedic trauma has evolved over the last 70 to 80 years. And that's largely because of the rise in polytrauma as well. Because our knowledge on polytrauma has significantly increased, because we have a large sum of polytrauma patients, initially in the Western world, but now in low and middle income countries as well. So how we approach these patients has also evolved, because the evidence base has been building up around it. So before the 1950s, patients with sustained polytrauma were considered too sick to operate, and all the effort was made towards stabilizing them. So stabilizing them, preventing ARDS, preventing multi-organ failure. And no operations were done for these patients. And it was believed that there was no benefit from early stabilization of fractures and other types of injuries. But evidence against that started to build up, and there was evidence showing that there is benefits for early fracture stabilization. But despite that, actually, too sick to operate, the concept of too sick to operate on persisted for longer than it should have, and that had catastrophic consequences as well. So here, this is showing you a research done in the 70s. This is a retrospective study. They looked at patients for whom early primary fixation was done from 1969 to 1974. And early immobilization, they showed that early immobilization was possible for 29 out of the 47 patients in the first 3 months. They had only one early death, and the majority returned to work within the first 16 months post-injury, and there were less complications and less hospital care. So this was evidence showing that polytrauma shouldn't equate to no orthopedic surgery. And in fact, some patients would benefit from early mobilization, early stabilization of the fractures. And in this study, they actually even included patients who received internal fixation following post-trauma, following trauma, and they showed that these patients, most of them did well. Here's another evidence building up against the concept of too sick to operate or no surgery for trauma patients. So these were 58 patients treated with external and internal fixation, and they showed that early fixation was well tolerated, and early fixation and prophylactic immobilization had better outcomes and less incidence of ARDS and shorter hospital stay and less risk of infection as well. So this was done in the 1980s. So there's another significant study done in the 80s that was actually the turning point that made a difference in early fracture care and moved from too sick to operate, moved surgeons from too sick to operate to early total care philosophy. So too sick to operate was replaced by too sick not to operate, because there was evidence showing that early stabilization or a fracture or early immobilization could be linked to less incidence of ARDS, less incidence of other pulmonary complications like fat embolism, pneumonia, and shorter hospital stay and shorter ICU stay. So this is the game changer. So this was the study done in the 1980s. It was a randomized controlled trial, so it was a much stronger evidence base than the retrospective studies I mentioned before. And it had a larger sample size with 178 patients with femur shaft fractures with or without associated injuries. And they were all, the only exclusion criteria were patients above the age of 65 and no hip fractures, because as you know, senile patients with fragility fractures have many more confounders or many more comorbidities that could result in ARDS than just the trauma. So they used very strong parameters, like they used biochemical parameters as well, like arterial blood gas. They also used in the injury severity score, the time of admission, pulmonary function, and hospital stay in the ICU as their parameters for the study. And the results showed that delayed fracture stabilization was associated with increased pulmonary complications like ARDS, fat embolism, and pneumonia, and a longer hospital stay and longer days in the ICU, and it was also much more expensive. So after this study, the approach to polytrauma with respect to orthopedic injuries completely shifted. So there was a variety of unexpected complications related to the early stabilization of long bone fractures. However, because the practice now changed and now surgeons were They went from too sick to operate to too sick to not operate. So now they were doing fixations, definitive fixations for all patients with polytrauma in an effort to prevent pulmonary complications, or even because now they think that pulmonary complications are not related to fixation and that it was safe to operate now. But with more surgeons or more trauma centers doing early total care, that means operating on every fracture following trauma, following for polytrauma. Now there's started, so the opposite evidence started to build up. So they started to see these complications like ARDS mainly developed in patients who had chest injuries, severe hemodynamic shock, and increased and cases where intramedullary nail reaming was done with or without thoracic trauma. So the conclusion was that early total care was not for everyone. So we know about the first hit and the second hit phenomena, and we know that surgery is actually controlled trauma. So now we have to decide, so which patients are fit for early total care and which are not? What kind of surgery should be done and when should it be done? So which patient, what kind of surgery, and when should that surgery be done are important decisions. So today for us, it's very clear that both the type and severity of injury, that is the first hit phenomenon, predisposes the borderline patient to deterioration after surgery. And the type of surgery, like that is the second hit phenomenon, poses a varying burden on the patient's biological reserve. So the individual biological response is important to note, and that might predispose them to adverse outcomes. So now we know early total care is not for everyone. So to briefly recap the evolution of fracture care in polytrauma, we moved from too sick to operate on, to too sick not to operate on, to early, not knowing that early total care is not for everyone. And now the concept of damage control comes into the picture. So the concept of damage control was birthed to answer these questions. That is, which patients should be operated on, what kind of surgery should be done, and when should it be done. So this was like a development in the concept. Because the burden of polytrauma is also a very recent problem for most orthopedic services. So in order to apply the concept of damage control orthopedics, it's important to classify patients based behind these symptoms. But just to give you a historical recap or the historical background on damage control, the concept of damage control is actually taken from the US Navy shipboard doctrine. It's developed to control fire and flooding in order to save the ship. So the concept is if there's a flooding or a fire, it's important to stop the flooding and to stop the fire. These are the first steps. And then the next steps will be either to build a structure to prevent structural collapse or to prevent sinking. So this parallels with what we do with polytrauma patients with respect to orthopedic surgery. So we're not trying to for perfect fixation. We're not going for perfect fixation. We're not going for disability prevention in the first few days or few hours. Initially, we're going for stabilization, not making the problem worse or stopping the cascade of problems that are ensuing. So that's the first step. So this is where the concept of damage control comes in from. So to define it, it's an approach that contains and stabilizes orthopedic injuries so that the patient's overall physiology can improve and not get worse. That's the most important thing. The purpose is to avoid worsening of the patient's condition by a second hit of a major orthopedic procedure. So we know surgery is controlled trauma and causes a secondary hit. So we know that damage control surgery is also not for everyone with multiple fractures or several injuries. So right patient, right procedure, right timing is very important. Most of you might be familiar with the molecular cascade that follows trauma, because trauma is not just, all traumas are not orthopedic cases, but we know that majority of trauma patients sustain orthopedic injuries. However, most of us are familiar with the cases of trauma, whether it be orthopedic or otherwise. So the patient's ability to resolve, we know that a wound or injury results in an inflammatory cascade, and the patient's ability to resolve this inflammatory insult depends on the magnitude of the injury, the patient's systemic metabolic response, which is determined by multiple factors, including the sex of the patient and other metabolic conditions the patient might have, and also whatever interventions follows. So systemic metabolic, bring out the graph, that's better. Inflammatory response procedure, which is a process that's there to balance it out, because you know, our body is, our whole system is geared toward exaggerated pro-inflammatory reaction, very damaging, and that damage is by the body. So should this balance be lost, that will result in significant complications. So there are different serum inflammatory markers. The acute phase reactants are quite popular. Everybody knows them. But in our case, for orthopedic polytrauma cases, and in general for polytrauma, I think IL-6 is the one to pay attention to, because there are multiple studies indicating that the level of IL-6 within the first few hours post-trauma can be used to predict the chances of multi-organ dysfunction. So in advanced trauma centers, they actually measure the IL-6 level, and if it exceeds 500, that indicates that there's a direct correlation to multi-organ dysfunction. So when you think of polytrauma, think of the inflammatory marker IL-6. I know the others are like CRP is very popular for infection, and the others for different other causes of sears. So, but for trauma, IL-6 is the one to note. So, so now we know the how to categorize the scoring systems for trauma. We have some familiarity to the molecular aspects of trauma. We know that the inflammatory cascade is stimulated or initiated by an injury, and the loss of the balance is what causes an exaggerated reaction, causing further damage to the body and the different systems. But all trauma patients will not have the same molecular cascade. So we need to know which patients, how to classify our traumatized patients. So we can broadly classify them in 4 categories. So some patients have little to no evidence of systemic inflammation, and no multi-organ dysfunction develops in these patients. Some of them mount a mild inflammatory response, resulting in a mild form of sears, which rapidly resolves, and others develop as sears that may or may not progress and have a higher risk of death. And some have a very severe course of inflammatory response or sears, and these patients are very at risk for multi-organ dysfunction and death. And also a second hit would result in severe deterioration in these borderline and severe patients. So now we have to decide which patients are susceptible to the second hit phenomenon. So the whole concept of damage control orthopedics is about preventing second hit phenomenon. So now we have to decide which patients can tolerate definitive fixation and which ones require damage control approach out of these. So this is just some scientific background, like this is what kind of molecular cascade ensues after a patient sustains trauma. So there are multiple theories. There's a microphage theory, where macrophages who are already primed result in like production of pro-inflammatory cytokines, circulatory injury resulting in high spikes of cytokines, same inflammatory cytokines, the gut hypothesis, and the one we heavily rely on, or heavily rely on to make our decisions, or to serve as the evidence base for why we use damage control orthopedics, is the two-hit theory, where I'll show you a graph in a sec. Yeah, so here you go. Like, there's a first hit, which is the trauma, infection, shock, whatever. Then there's an inflammatory response, which may subside in and of itself. And then if there are primed macrophages, there is an amplified inflammatory response. And like, if there is a second event, if there is a further anything, surgery, another infection, exposure to toxins, ischemia. So surgery causes ischemia. So like, that's why it's a second hit event. And any of these secondary hits will result in a much more amplified inflammatory response and multi-organ dysfunction, and subsequently the triad of death, and the patient will succumb to that. So this is the concept of the two-hit event, very briefly described. So this is a more extensive description of the two-hit event. So as I've said, it's very patient dependent based on the patient's age. Not all patients will respond the same way to the same trauma. So we should be able to somehow assess the kind of inflammatory response that specific patient has, in order to determine which kinds of surgeries or which kinds of interventions, other than our resuscitative efforts, are acceptable or would actually benefit the patient. So it's a balancing act, and we want to be very specific to our patients. Here you'll note that interleukin-6, an increased interleukin-6 has a potential to identify patients who will develop a multi-organ dysfunction or die. So so we rely on that to decide, okay, does this patient have a severe inflammatory response to this trauma that our intervention will actually make things worse instead of preventing ARDS? Are we going to cause ARDS? That's essentially what we're trying to decide. Are we going to cause multi-organ dysfunction, or is our intervention or is our surgery going to prevent multi-organ dysfunction? And to make that decision, one of the parameters we use is interleukin-6. So like I've mentioned, I've showed you a grading system for our patients, and we can be more comprehensive, like include the severity of injury or presence of other injuries and hemodynamic status, and broadly classify them as stable patients, borderline patients, unstable, and in extremes, or patients on the way to leave us. That's essentially what it means. So we need to know which ones are borderline. I mean, we may not always use this specific parameters, but for someone like working in the emergency room, who needs to decide, am I going to continue stabilizing this patient? So that's essentially, I understand most of the attendees today may not be orthopedic surgeons or are not orthopedic surgeons. But most of you may end up working in different emergency rooms. So when you have a polytrauma patient and you want to decide, is this patient, should I keep resuscitating this patient and not bother consulting with the orthopedic side? Should I not push them to operate or to stabilize the fractures or not? So you're trying to decide the course of management for this patient. Would they benefit from early intervention? Would they benefit from early provisional stabilization? Or should I just continue my resuscitative efforts because any kind of intervention in this patient will cause a secondary hit? That's essentially what we're trying to decide here. So is your patient borderline? So is the injury severity score above 40? Does the patient have hypothermia? And many of the other mentioned parameters could guide you to decide to continue to keep that patient in the emergency room with multiple resuscitative efforts and keep them in the ICU without any surgical interventions, or should we make them stable enough to make it to the OR? Because surgery could benefit them as well, because early stabilization, as I've showed you, has multiple research showing that it could help them not develop ARDS, because an unstable fracture is a continuous source of an inflammatory, an unstable fracture or a bleeding fracture is a continuous source of further strain on the homeostasis of the patient. So they'll result in hemodynamic instability. It will stimulate further inflammatory, stimulate the inflammatory cascade. So a moving fracture also increases the risk of fat embolism, like fat embolism fat showers are like as high as 70 to 80% of femur shaft fracture patients show evidence of a fat shower in their lungs post-fracture. So it's not, you put that on top of a chest injury or any kind of bleeder anywhere, internal hemorrhage, or a bleeding open fracture, that's another instigator. So stabilizing it can be a lifesaver for the patient. So this is the decision you're trying to make in these polytrauma patients. So are they going to benefit from surgery? Are they not? Should I keep resuscitating them? Should I should I make them stable enough for the OR? So when should I make my consultations? That's the kind of thing you should know as someone who works in the ER. So I'm not going, this is very detailed, but you'll have the slides so you can go through them whenever you need them. But these are the parameters we use to classify our patients. They're very detailed. Most of them we don't have, like the end resuscitation goals we use are usually vital sign and urine output. We rarely have lactate levels and base deficit, but those are the most reliable ones, as you know. But it's good to know them because we're not always going to be a poor country, and at some point we will have these things. So this is a very comprehensive list to classify which patients are fit for early total care, which patients are fit for damage control, or which patients are fit for damage control. So this is just to remind you that an injury results in hemorrhage. Hemorrhage results in the triad of death with acidosis, hypothermia, and it's a vicious cycle. So keep note of that. So yeah, like I've said, how do we select patients? We may use physiologic parameters or based on injury the complexity of the injury. So the table I've shown you, this includes both the physiological parameters as well as the severity of the injury to make the selection. So this is just to present it in a more detailed way. Of course, these are not hard and fast rules, and these parameters are open to more research, and they might shift. And we're also now currently seeing a shift very recently that maybe some of them are very too strict, like some of the parameters are too strict. Maybe we're classifying patients who may be fit for surgery and like delaying their surgery unnecessarily because of our very strict parameters that we choose to use or evidence has shown us to use. So systolic blood pressure less than 90. I mean, these are numbers that you should go over yourselves. But the whole concept is, how do we decide? And these guide us to decide. From the orthopedic injury types, now we're seeing a rise in severe pelvic fractures. And pelvic fractures are definitely not just an orthopedic case. Like if you see a patient with a pelvic fracture, it's best to treat them as polytrauma patients unless proven otherwise, unless the pelvic fracture has been proven to be a stable kind of pelvic fracture. Please approach all of them as polytrauma patients, because most of them will have hemodynamic instability, and hemodynamic instability is a systemic crisis. As you know, it affects every organ, every corner of the body, and also they will have an inflammatory cascade as well, a very severe one. And usually pelvic fractures are associated with other visceral injuries like vaginal, bowel, and bladder injuries. So there's no such thing as far as I'm concerned, and as far as you should be too, all pelvic fracture patients are polytrauma patients, even though like it's a single site fracture and it's not at 2 anatomic sites, whatever the definition of polytrauma may be. But these patients usually should be treated like polytrauma patients unless proven otherwise. It's a really serious cause of morbidity and mortality. And yeah, so this is just a detailed reiteration of how to select these patients based on the injury itself. Like I've said, pelvic fractures, definitely damage control. Bilateral femur shaft fractures, definitely damage control. Periarticular fractures, in some cases, yes. Multiple long bone fractures, and mangled extremities, anything that causes severe blood loss, associated severe chest trauma, traumatic brain injury, and also the patient's age is very important. Yeah, so when we have head injury, how do we approach this patient? So let's say we have a femur shaft fracture with a moderate TBI. So all moderate and severe TBI patients with orthopedic cases, because should be treated with damage control orthopedics. But mild traumatic brain injury patients with orthopedic injury can be treated with early total care. The reason we specifically talk about head injuries is because it's very important that we maintain the cerebral perfusion pressure, and head trauma patients do not tolerate a drop in the mean arterial pressure like other patients. And we also need to note they're going to have a rise in ICP and a drop in the mean arterial pressure. So cerebral perfusion pressure is going to be compromised. There's a risk that's going to be compromised. So we want to be very careful with head trauma patients, but also we don't want to be too careful. Like if they have a mild TBI, it might be in their best interest to be actually operated, because an open fracture, an unstable fracture is a continuous site of blood loss, and it's an instigator of an continuous inflammation. So it's a continued strain on the whole hemodynamic system. So if we need to base our decisions on the evidence, just because a patient has a head injury doesn't mean orthopedic surgery is a no-no. Yeah, and another important decision, maybe it might not be that important for most attendees, is when we decide to shift from a temporary stabilization measure like an external fixation to internal fixation. That's it's quite a headache for us as well, and the studies are always changing, but we want to keep that balance. Is the patient now stable enough? Has the system fully recovered? Have we achieved our end resuscitation goals? And have we maintained that so that we can move now to an internal fixation, and our patients might benefit from that? So that's the kind of decisions that maybe, that's an orthopedic surgeon headache, actually, it's not yours. So damage control orthopedics can be summed up as initially we do early temporary external fixation stabilization, then we continue to resuscitate the patient, and then we do a delayed definitive management. These I'm sure most of you are familiar with, but just to remind you, these are the end points of resuscitation for us, in addition to vital signs and adequate urine output. If we have them, we might use that. We may not have arterial blood gas monitoring. We have it in some centers, but they're not readily available for us. But we can actually measure the IVC diameter. Like bedside ultrasound is more and more available these days, and this is actually an end point of resuscitation that a lot of emergency rooms or ICUs use nowadays in our setups as well. The IVC diameter is a very reliable one, and it's also an easy one to do, other than the operator dependence resulting from it being an ultrasound investigation. That's the only downside to IVC diameter, I guess. Okay, so how efficient is damage control orthopedics, and when do we decide to do our secondary procedures? So a lot of things have to be considered. The safety, the efficacy, timing of conversion to definitive treatment, and the safety to conversion. It's actually very controversial. So the risk of infection rises after 14 days. So we want to convert whatever external fixation we've applied back to an internal fixation or definitive treatment within that time. We don't want to pass that time, but we know that the IL-6 levels or interleukin levels in general, they spike between 3 to 5 days. So those times are definitely a no-no for any kind of surgical intervention. But after the 5th day, it kind of starts to drop, and that's when we consider second definitive surgeries or secondary procedures. Because this might not be. So yeah, this is what I've been saying. So day 1, if the patient is fit, we can fix everything. After, or if the patient is not borderline or severely unstable patient, then we go for damage control orthopedics based on the parameters I've been talking about, like the physiological parameters and also the injury severity scores. So if the patient has no response to resuscitation, then resuscitation is the priority. They won't be fit for any kind of surgery. So in the 3rd to 5th day, as I've said, like that's a hyperinflammation period. The immune system is severely compromised, as you know, and they are at risk for any kind of if we do any kind of procedure in this time, they're at risk for secondary hits. They're also at risk for infection. So we want to avoid that. So at least 4 days of delay is a must. And early secondary surgeries are associated with an increased risk of IL-6 compared to like late surgeries in most cases. But also we want to balance out the risk of infection as well. So that's a balancing act. Yeah, so this is what I've been saying. The longer we wait, the higher the risk of infection. And 14 days or 2 weeks is usually the cutoff that we tend to use. So this is a summary. You can think of it as a summary or a flow chart to make our decisions on which patients are fit for damage control and which are not. So there's a trauma, which is the first hit, and we continue our resuscitation. And we monitor our resuscitation, and we do our lactate levels, base excess, interleukin-6. Like I've said, like for trauma, interleukin-6 is the most reliable inflammatory marker we should measure if we can. So other clinical methods, clinical parameters like the sign, urine output, all of them are there. And then we reassess the patient's condition. Is our patient stable now? Is the patient borderline? Is the patient unstable? Or is the patient in the brink of death? So if the patient is stable or borderline, we make our decision. Are we going to do an early total care? And we might go with that. And we also decide, that means we essentially decide the type of intervention that we do. If they're unstable and in the brink of death, we might decide to do damage control orthopedics. They might benefit from that. Very short surgeries and the kind of interventions that should, the kind of surgeries that should end within 30 minutes. Just enough effort to stabilize the fracture and not make it a site of more trouble for the whole body. That's essentially what damage control is. So mostly it's external fixation, pelvic fixators, C-clamps, things like that. So, and then we go for definitive stabilization. We consider that after 4 days. I want to briefly introduce you to a new concept that's challenging damage control orthopedics in our practice, which is the early appropriate care. So there was a retrospective study done in 1,442 patients with pelvic fracture, spine, and femur shaft fracture in 2013. So this study showed that like maybe damage control, the parameters we use for damage control are too conservative. Maybe we don't need to set up the end resuscitation goal for the lactate level at 4 millimoles per liter. Below, maybe 4 is too high of a number. Maybe if it's below 2.5, maybe that's enough. It's above that. So it's like adjusting the parameters that we have that we already use. I mean, we don't use it, but of course they use it. And it's just a concept that I wanted to introduce you to. It may not have clinical implications for us. It definitely doesn't in our practice because we don't have the luxurious parameters that they use. But I wanted you to know that things always change, and damage control orthopedics is also being seriously challenged also. So yeah, so early appropriate care proposes that definite management of mechanically unstable fractures of the axial, skeleton, and long bone within 36 hours of injury, as long as the patient has demonstrated response to resuscitation is safe. So our endpoints of resuscitation: improvement of acidosis with with lactate level less than 4 millimoles per liter might be enough. We don't have to wait for it to drop to less than 2.5, and pH greater than 7.2 might be enough. And basis excess of above 5.5 might be enough. So that's what they're proposing, and they have studies to back them up for that. So they say that early appropriate care improved complication profile, shorter hospital stay, improved hospital income, and also much better use of hospital and operative theater resources. So even at, but for us, early damage control orthopedics is what we use now, what we can use, and we make those decisions on who's fit and or not using the parameters I've mentioned. And it's a multidisciplinary approach for polytrauma patients, and also the decision is multidisciplinary. Most of we make these decisions in collaboration with emergency physicians and anesthesiologists. So we decide if the secondary hits is a fair risk to take or not. So that's how we decide. So back to our case, you remember a 46-year-old male patient who sustained road traffic injury. He was a pedestrian, and he presented with neck pain, transient loss of consciousness, bilateral lower limb pain, and vital signs were deranged. So after resuscitation, vital signs are now within the normal range, and they are stable. And these are his imagings. So I guess because the session is not interactive, I'll go ahead and tell you how we should approach this patient. So in terms of the physiologic parameters, the vignette is telling us that vital signs are stable, but we know that those are not the endpoints of resuscitation we rely on, because vital signs are the first to be deranged, but the first to recover as well. They are not, they don't actually tell us the microperfusion, right? So we don't rely on them to completely say like this patient has been fully resuscitated now because his pulse rate has dropped or his BP has risen, right? We don't completely rely on them. And in addition to that, you see the fracture, the types of fracture the patient has. The patient has a bilateral femur fracture, as well as left side comminuted tibial fracture. So severe injuries to anatomic sites in terms of injury complex, the injury severity, this patient should receive damage control orthopedics. And that's how we will make decisions in our patients. That's all I had for you. If you have any outstanding questions, I'll be happy to answer them. So I'm going to stop screen sharing and go to the question box.
Thank you very much, Doctor. I believe there are 4 questions in the Q&A section, and participants who have questions, you can direct your questions, you can write your questions in the Q&A section, so doctor can answer them. Back to you.
What should be action if a patient comes to ER gunshot and sustained with partial or complete muscle tear? I would have to see the patient to decide on that. This is not a very, this doesn't tell me the severity of the injury. Gunshot wound sustained with partial or complete muscle tear. Just muscle tear, no fracture. Okay, what's the proposal when there's a neurovascular bundle compromise in terms of who goes first? Vascular or orthopedic or plastic? This is a very good question. If I was in the ER and this is what my patient needed, I'd call orthopedics and vascular side simultaneously, and they'll go into the OR. We usually go into the OR at the same time, and we stabilize the fracture first, and then they do their repair, because their repair is, if they choose to do any kind of end-to-end repair or conduits or any grafting, they require that the musculoskeletal injury be stabilized first, because their surgical procedures, their surgical intervention is delicate and it requires stability. So usually we put in the X-fix as soon as possible, like 15 minutes, 20 minutes is how much we would take, usually like less than that even. And then they'll go ahead and do their vascular repair. So that's a good question. And then plastics usually don't, they're not required on an emergency basis, but we'll reconsult them after everything else is done, and they'll go on through a second surgery. But if there's a, like if you need to do a flap, any kind of soft tissue cover for your bone, then the orthopedic surgeon themselves will do that. And then for any difficulty and cosmetic reasons, the plastic side will be involved later on. Okay, another good question. Effect of genetics on systemic response to trauma, and especially with gene. Okay, this is way out above my expertise, and I don't think anyone would name a specific gene for you, but we know that we don't all respond, we don't all have the same inflammatory response, and even in some patients, like patients who have a primary severe combined immune deficiency, like a primary immune deficiency conditions like severe combined immune deficiency, those patients might not mount any kind of inflammatory response, and that's also not a good thing. That essentially means their immune system is not functioning. So the inflammatory response, the systemic response, is a protective response. It usually works for us but it's when it's a hypervigilant or hyper-responsive, then it leads to more damage, more harm than good. But I don't know which genes affect that. How long it takes a teared muscle to heal? A muscle will never heal back to exactly where it is. It's going to scar. It's going to heal with collagen fibers, and it's going to scar. It's never going to be the contractile structure or the actin myosin setup or filaments will never be reconstructed once they're damaged. It will never go back to how it used to be. Maybe with regenerative medicine in the future, we'll have that, but we don't have it now. The patient comes to ER with gunshot and sustained complete brachioradialis muscle tear with or without fracture. What's our action in this case? Okay, so this will become considered major soft tissue injury. Initially, you'd want to, if the brachial plexus is torn, then you need to check all the neurovascular bundles around the brachioradialis. I'm not sure which site it's torn at, but wherever it is. But if there's no fracture, we make sure that it's a fresh wound. If it's a fresh wound, we'll stitch it back. If it's not, we'll leave it open and let it heal by secondary intention, like we do for other soft tissue injuries. No need for skeletal stabilization, but it will never go back to where it was. Okay, what is your comment on the application of early total care in our setup? I mean, we can't get those lab markers as needed. Yeah, exactly. So even damage control orthopedics is an art for us more than a science, because we still don't have the parameters that we need. So we tend to make our decisions more on the injury severity scores than we do on the physiologic parameters. So early total care is good. It's good to keep the concept in mind, especially if we start getting lactate levels for our patients. We can use it, but for now, it's just knowledge. We're not practicing it. Why interleukin-6 is good for predicting outcomes in trauma patients? Yeah, so I mean, this is research. So they were trying to decide. So we know that there are so many pro-inflammatory markers, so many of them, and some of them are outstanding as biochemical markers for some diseases. And for trauma, they found through studies that interleukin-6 levels were linked to higher rates of, they were predictors, essentially. They found that interleukin-6 level was a good predictor, a reliable predictor of multi-organ dysfunction later on. So early measures of interleukin-6 within the first few hours were linked to were good predictors of multi-organ dysfunction later on. So that's why it's a good predictor, because of studies showing that out of all the cytokines, out of all the pro-inflammatory markers, they found that interleukin-6 was the most reliable. Are there any practical parameters to follow prior to intervention from your experience in our setup that you would want to mention or reiterate? I.e., are the K-Val index and the urine output the only ones we could rely on if we don't have arterial blood gas levels? Essentially, yeah, that's what we rely on. I've seen in some centers that ABG was available, and it can be used. I've seen it used for other conditions in different ICUs. They use it in ICUs more and more now, but maybe we can use them for our trauma patients as well in the future. But now we heavily rely on vital signs and the urine output, because we don't have access to more fancier investigations, although we know that they're not the most reliable measures of, they're not the most reliable and resuscitation measures. Which bone is easier to heal soon? This is a very difficult question to answer, because bone healing has a lot of factors affecting it, from age to to site, to type of fracture, to overall metabolic condition of the patient, to other conditions like diabetes, RVI, anemia, local ischemia, local infection, whether it's open or closed. So I can't specifically tell you which bone heals the fastest. Early appropriate care versus early total care, their difference. Yeah, so early total care means fix everything with definitive fixation. That means if a patient has bilateral femur shaft fracture with, let's say, chest contusion, just take him to the OR and do bilateral nailing without considering what that secondary hit would do to the patient. But early appropriate care means resuscitate the patient, reassess, just like we do for damage control orthopedics, assess the condition the patient is in, and then make your decision. Is the patient going to benefit more from surgery or from definitive surgery, or is the patient, does the patient require damage control orthopedics, or does the patient require further resuscitation prior to surgery? So you already have your parameters, studied parameters. Using that, you make that decision. Yeah. What are the second hit phenomenon? Second hit phenomenon essentially means the worsening of the first hit. That means further hemodynamic instability, further inflammatory response, and the continuation of that cascade because of cause that is very similar to the first hit. Like it might be like if the patient had trauma and now you do surgery, which is a controlled trauma, again, that's your second hit. It will have the same effect, but since the patient's system is already compromised and has been damaged by the first hit or sensitized or stimulated by the first hit, a second hit will push them off the rails. Which trauma score is simple and good to use in our setup? I would say the injury severity score, because abbreviated injury scale is much easier to memorize. Like 1 is mild, 2 is moderate, 3 is severe, 4 is very severe. Like it goes on like that, so you can easily remember it. So abbreviated and injury severity score uses the abbreviated injury scale, so you can use that. Do we have a system or facility where we can reach patients at the site of injury via ambulance or paramedic support so that patients can be handled on site promptly and professionally? I don't know. That's a very difficult question to answer. Do we have a system or facility? We're trying to build trauma centers. That's all I can say, because trauma is on the rise and we're trying to respond to it as a health system, as a country, as a like from hospital admins basis, and even worldwide. It's called the silent pandemic, the silent epidemic, because trauma is rising everywhere in the world consistently for the last 20 years. Has been rising as a cause of death, especially low and middle income countries. So it is actually an epidemic. It's just not an addressed epidemic or talked about as much. But if you see the stats, it is on the rise in a degree that should concern all of us. For us, if you take our patient, like we did a 30-year survey for our department at Sabah University at Gramps Hospital, and trauma has been on the rise, like not just for the orthopedic service, but for the emergency service as well. It accounts for 70% of the surgical emergencies, more than 70%. It's actually still rising of the surgical emergencies presenting to the Gramps Hospital. 30 years ago, majority of the orthopedic service used to be concerned with deformity. Now, more than 80% of our beds are occupied by trauma patients. So it is actually an epidemic, and we're trying to respond to it. Like most hospitals are trying to build designated trauma centers. Some hospitals have had success, like Asa University and Alert, and maybe Abate Hospital is also a result of that response. So I'm not a politician, but I know there's some effort being made, although it's not enough. So that's what we can do. But the reason we don't have designated trauma centers, in my opinion, is because we didn't have as much trauma that we couldn't handle within our departments, but now we need designated trauma centers. That's my opinion on that.
So thank you so much, Doctor, for this third time on our platform to present such an amazing session. I hope to see you in a future setup. Thank you so much. Have a good night.